Hi everyone, welcome to Oceania. Has anyone got any questions for us? I might start off by asking you a question, Rahul. For those of you that know me, you'll understand that my area of research is around PICU long-term outcomes, and obviously part of that is care of the parent as well as the child. And I wondered if you've considered translating some of this mindfulness work to parents within the PICU.
Right. So yeah, that's a good thought, and this came to my mind as well. But with the COVID, we had a center where there was parents could go and spend time. So with the COVID, there is limitations. But it's a possibility. We can start some mindfulness sessions for the parents, especially those who are very sick, and kids very sick in the ICU. I know that oncology is doing some of it in our institute, and with the resources, we should be able to do that. Have a Zoom session or in-person mindfulness session for the family.
Do you think that there is, given that, well, particularly in Australia, our length of PICU stay is quite short, that there's still benefit in 1 or 2 sessions for parents as opposed to ongoing over 6 months or something like that? Or is it more about setting them up to continue that on at home?
I think the idea is to just having them something to try, and if they like it, if they enjoy it, they can continue that at home. A lot of the times what happens, and this happened with me as well, when I heard about this mindfulness meditation, and I was like, this is not for me. But then I went to this conference, Mind Matters in Adelaide, and they had a session about mindfulness well-being, and I did one session and I enjoyed it. So I thought, why not give it a go? And I think we just, as especially a doctor, a medical person, male, we just portray sometimes that I'm strong, I don't need all these things, and worth giving it a try and see whether you like it or not. And same things with parents as well. They need some support, they need to look after themselves, and whatever we try, we have psychologists, allied health, and resources available, but unless we take initiative, we don't see any benefit. So it's kind of, you have support system available as well as you take some initiative and see whether it works for you or not.
Building on that, hi Tessa. Tessa's asked a question around advice on how to implement mindfulness from an operational perspective. So how do you prioritize getting staff there? How do you prioritize a whole of unit culture change, that sort of stuff? Or is that the $1 million question?
That's a $1 million question. That's right. I think once you believe in it, that it's helpful and you are finding it useful for yourself as well as some of the team members, you try to implement it. We had a bit of initial struggle, but there was a lot of support from the director as well as the organization, nursing unit manager, and we found a time which is not ideal for everyone, but we get at least 10 to 15 people at any time, sometimes 2 or 3, and we just organize a session. These are available so we do it via Teams, and you can practice it from home as well. A lot of the times what happens is, the team leaders, they struggle to send the staff, and we have non-clinical staff or some of the admin staff just relieving the admin person. They chip in, they liked it, they suggest to their colleague, why don't you try, and they found it useful. So that's how it is. You just, as a team, as a unit, you decide a time, one of you can take the session and then go forward. I think sometimes what happened is one session I thought, this is it, I'm not going to do it anymore, because after 5 minutes no one was there, and when I thought about that, we got 15 people coming in. So, you just have to continue doing it. And if they find it useful, like we did a survey, post survey, we had 220 participants. 45 of them, they have quite encouraging words about, about the whole session. One of the male nurse, he told me, I was so happy that I sent some of my colleagues to attend the session. He couldn't do it for 5 months, but at the end of the 5 months, he did the session and he enjoyed it, and he was very thankful, and he was like, it was good that I encourage other people to join the session. So I think worth give it a go. We have a team session. If you want to try and join us, we can send you a link, and or we can organize a session for your team as well.
So you're encouraging everyone from around the world to join in your team's mindfulness sessions, Rahul?
Yeah, sure. Or we can organize a different session for them.
Well done. Thank you. Ali, we've got a question from you from Lisa. Thank you, Lisa. She wants to know about, with early mobilisation programs, a lot of them talk about the concept of celebrating the wins, the small steps that we have to build and maintain that momentum. How do we in the Children's Hospital in Queensland celebrate our wins in terms of early mobilisation and liberation? And do we have particular platforms that we use to do that?
Thanks, Deb, and thanks for the question, Lisa. Yeah, I think it's really important that we do celebrate the wins, because I'm very mindful that it's been a culture change, and hugely respectful to all our colleagues in PICU for embracing the change. And we do share the wins, celebrate the wins. So one way we do that is I try to, with parental and family consent, take photos and videos of patients participating in the early mobility program, because sometimes that mobility will just be within the bed space and will only be seen by the people within that bed space. So I think it's really important to see for the rest of the unit to be able to see what people are achieving and what they're able to do. So we share that on a weekly basis on our PICU bundle newsletter, which is emailed to all PICU staff, and they get to see that. And that, yeah, I feel like that has created talk in the staff room, and it has created sort of celebration of that. When we are moving patients around the unit, I also really try to engage other staff as we're moving. So that can be from porter staff to cleaning staff to medical staff to nursing staff. And I try to build that momentum for the child, and we all go, yeah, you're doing a great job, or look, there's Dr. Rahul, look what we're doing. And I think that again makes other people feel involved, because we're all the team in the unit. It's not just the people that are actually doing the movement. We're all supporting that. So I think that works well in our unit to share that, celebrating the win, Lisa. And I think it's really important that we do celebrate those wins. We started off with our early mobility program in just a couple of bed spaces in our unit, so not everyone could see the wins. So by being able to share it, it made people feel more involved in seeing what our unit is able to achieve, which is really been wonderful to see.
Thanks, Ali. I think, what I'm noticing from both yourself and from Rahul is that for any of these initiatives, obviously there's a key driver to keep pushing the message and the activity and keep that alive, but there's a certain amount of contagion within the staff once they see the positive aspects of it and get the feel goods from it, that they then celebrate that with their other staff members. But it does take quite a bit of initiative from a few key people to keep driving. And as Rahul said, there's times where he's felt like giving it up just because a few people didn't turn up on time. So I think in talking about celebrating the wins, we also need to celebrate the wins within the key drivers to make sure that we've still got the momentum and the energy to keep driving these initiatives forward.
And it's really important. I've noticed, Deb, that it's really built confidence between staff at all levels. Once they see something done once, they're kind of like, oh, well, we can try that too. Oh, that went well. Or, oh, you know, there was something that could have been changed. We could do that differently. What did we learn from that? And I think that's so important for people to see as well. Yes, it's great to celebrate the wins, but we also have to learn from each experience.
Yeah, thanks, Sally. And hello, Switzerland. It's Anne Sylvie. She has a question, presuming for me, about budgeting follow-up. And I'm assuming, Anne Sylvie, you're talking about long-term follow-up research and what financing mechanism should be put in place and who is paying. Unfortunately, it's a lot of grant writing from my perspective at the moment. And we know that we have tried centralised follow-up in the state of Queensland previously, and that's where all the children and all the families return back to our hospital, and they have the full follow-up, more diagnostic rather than screening. And the difficulty with that is that there's a cost with relocating families, there's a cost with accommodating them for an overnight series, and the government really doesn't want to pay for that. So for those that aren't aware, we have a single healthcare system in Australia, so all care provided for children admitted to a public hospital is free. So all children who are admitted to a PICU, that is free. And so the parents are not charged for them to come back to Brisbane, for example, to have follow-up. But we can't do that anymore because it was so financially and from a human resource cost prohibitive. So now at the moment, the only thing that is driving follow-up and the work we're doing here in Australia is a good old grant. And that in itself is still quite expensive. At some point, it will become business as usual, but we need to find a healthcare model and delivery system that will support follow-up that is not centralised, and where the costs are shared across both primary healthcare and tertiary healthcare. Do we have any other questions? Hallie, do you have any other burning questions that you would like to ask?
I guess I'll put a question back to you in terms of the long-term follow-up. And again, just looking forward and in terms of what you envisage will kind of operationally happen in terms of that? I know so it's not at a point yet. it's a vision.
Yeah, it's a vision. We know both internationally and nationally, or binationally for us, that PICU long-term outcomes has been prioritised as something important moving forward and moving from this paradigm of survival to survivorship. So that question is, you know, pretty set now that this is the way that we need to move forward. The difficulty is deciding on how to move forward. There is research being done, but there are some limitations and gaps in the research that has been done already and still now. And for example, there's been a lot of work done in either single cohorts or disease processes like sepsis or congenital hearts, and that's still very important. But you know, PICU is a very heterogeneous mix of children of all different ages, so all different developmental ages. What we've seen in the past is the use of singular domain tools. So we know that the PICS-P framework has identified several different domains, cognitive, physical, social, emotional, that we need to consider, and also the importance of the family and the parents in that model of care. The other thing is, you know, this question about can you do follow-up centrally? Can you do it regionally? What are the core outcomes that we should be looking at? So internationally now, as I mentioned, we've got the core outcome set that's been developed. and the group is now moving on to the core outcome measures. So as we continue to do this background foundation type work, we're getting closer and closer and more aligned to each other as to what we're doing. You know, I talked about GP shared care, but in the you know, Central America, the healthcare system is very different and children are followed up very differently. So we take our children with colds and flus and immunizations, for example, to our family GP. But in the United States, you take them to your pediatrician. So we need to understand what all the different types of health services and systems are as well to be able to get to that point. But ultimately, what everyone wants to see is some sort of follow-up for every child following their PICU admission. And whether we can narrow that down by identifying the risk factors for those children more likely to have adverse outcomes post-PICU, that would be even better. There's a question here from Anne Marie. In terms of retrievals, and I might actually throw that to you, Rahul, because none of our retrieval staff are on the line, but you would have done them, and I've done them a very, very long time ago. Is that how we transport these how do we staff our long transports? You know, Paul was talking about 8 to 10 hours for retrievals and things like that.
Yeah, so usually what we have in Queensland, Brisbane, the checker service, we have a retrieval nurse and a retrieval doctor on site. And then depending on the acuity and the sickness of the child, depends if you are going to send a senior registrar or a consultant doing the retrieval. We don't have a respiratory therapist, but the transport mode is by the Queensland Ambulance Service. And if it's a fixed wing or rotatory wing, we go to a destination. Sometimes it's a long journey, as Paul mentioned, and then, you know, there's the risk of fatigue as well, but it's kind of ICU going to the patient or in a rural remote area and bringing the patient back. So we have 2 teams during daytime and 1 team stationed at night, and then there's an on-call doctor and nurse on the floor. So if we require more people, we can manage amongst the staff in the unit. It is sometimes very long retrievals. The weather, you know, the flight can be quite shaky. And you just need that 10 to 12 hours after you finish your transport. I remember doing a 20 hours retrieval, you know, with the nurse, and that's the longest I have done. Some people have done longer than that, but then they managed to spend some time at the destination hospital to get some break and then come back in the fixed wing.
Yeah, it's certainly.
Yep.
No, you go.
You know, the nurses and the doctors, they are, you know, they go through a training and they have some buddy shifts, and then they do the retrievals on their own.
Yeah, it's certainly within Australia, and obviously our experiences are from within Queensland. The distances travelled are quite extensive. Paul showed a map of the UK in the middle of Queensland. You can overlay the map of Australia over the United States, and it's pretty much the same size, maybe just a little bit smaller. And so for our retrievals, we're sort of covering off a quarter of the US in order to collect these children, and sometimes further, because our services often cover the Northern Territory, Northern New South Wales as well. And often we could actually include several different modes of transport within one retrieval alone, or we would have to bunny hop due to refueling the aircraft or something like that. So it is very much a challenge and fatigue for the staff, for the pilots, obviously, and also for the families. You know, this comes at a significant cost to the families to bring them to centralised tertiary care, which is not really central to Queensland. And so we then have to house our families down in Brisbane, and they're often separated families where dad and some of the children might be at home in their regional area, and we've got another parent down in Brisbane. So it brings immense challenges. And what we tend to find with our Indigenous communities is all manner of kin who come with the children. So often what we'll find is that the actual mother of the child will remain within the Indigenous community, but it'll be one of the extended aunts that might travel with the child. And that's within the culture here in Australia of our First Nations people is perfectly acceptable to do that as well. I think we've got some more questions coming through. Let's just have a look here. So in terms of the retrieval stuff, Raul, you're in the spotlight again. Inti Zaf is just asking about telemedicine and supporting the local hospitals to stabilise. Can you talk about this, particularly with low middle income countries where there's not such well-defined systems with telehealth? Have you got any experiences with that?
So, Zaf, we do use telemedicine to support in the initial stage as well as ongoing phase. But as you know, some of the times we get a call in panic, and when we use telemedicine, we think that the child may not need much support, and then just supporting the team and helping them, that does the work most of the time. But sometimes, what the referring hospital tell you and what you see, the patient is in a different condition, and the telemedicine helps at that time deciding, what level of support is required. Do the patient needs intubation? Sometimes we think about transporting, the anesthetist or a specialist closer to that hospital so that they can support until the retrieval team is there to transfer the patient to one of the pediatric intensive care unit. Considering this in the low middle income countries, they with the phones available, WhatsApp calls, they are utilizing that. Just with the COVID situation in India, and I was just talking to some of my friends, and what they said is a lot of these the discussions are and consultations are done on telemedicine these days via WhatsApp call or Skype call. So there is a role for that. It's not standardized, and the reference system, if they can have a referral hub where all the telemedicine calls can be directed with staff by experienced intensivist or anesthetist, and then the system could be much better. As you may be aware that the transport service, ambulance service is not as equipped compared to developed world. And there could be issues and there could be scope for improving that as well. So supporting the local hospitals as well as supporting the ambulance staff and educating, there's a lot of role of telemedicine. I've utilized it quite a lot. We have access from home as well. So when we are on nights or on weekends, not on the floor, we can log into our computer and do a telemedicine consult. We tell the referring hospitals as well if they have any concern or if they're not sure what's going on, we are happy to do a telemedicine and support you while our team arrives at the bedside.
Do you think that there's a role for the people that don't have the proper infrastructure to actually use the social media platforms? I know, for example, our ambulance service here in Queensland, they will FaceTime if the medical director wants to see what's going on.
Yeah, I think so, because seeing the patient, that gives a lot of valuable information compared to just hearing about observations and what's going on. Sometimes we're not able to make whether this patient is really sick or is just the treating team is panicking, and the telemedicine is really useful. And the intubation, sometimes I have come across a situation where one of the senior medical officer was just guiding about how to intubate and just supporting them remotely via telemedicine, and everything went well. So there's a lot of positive uh, outcome by using telemedicine, especially in sick patients.
And are you able to feed back and close that loop? So after you've done retrievals, do you get back in contact with the peripheral regional hospitals and sort of update them on the outcome of the retrieval and how they went? Are we at that point where we can close that loop?
We do that not very often. If it's a straightforward retrieval, then we usually get a call from the referring hospital. But if there are any concerns, or if you think sometimes you get a call and the registrar tells you that, the doctor called, then we call them and update them. Some of the nurses that we have started implementing is the retrieval team. Then they follow up with the referring hospital, especially if we transfer to regional centers, then we do a phone call to check on those patients. But updating the referring hospitals on regular basis, I think we should encourage our team to do more often.
And if you, we like to encourage our colleagues at other hospitals to contact us if they need support or anything like that. What's the governance or the legalities around people calling you and asking for your advice and then using that in other hospitals? Do you have a thought or opinion on that? That's just an extended question by Zaf.
So I think we are a retrieval service, and we do support. We advise on the management as well. It's a shared decision making. The patient is under the care of the treating team, and we are supporting that until our team arrives there. And I think the intention is, the best for the patient and the family. The retrieval services is a statewide service, and we encourage all the referring hospitals to call us and support them during the stressful time and looking after the sick child.
Yeah, and you obviously don't want to discourage that and change that engagement. Thanks, Rahul. I think we've got time for one more question, and this question is for you, Ali, from Sarah. She wants to know, and this is a really important question and something that we get asked quite a bit, about the negative feedback around early mobility, or what barriers we've seen to implementing it and trying to create this culture change in PICU. And then the second part to that question is around the Cpax and how we then use it within the early mobility program. So if you could just explain how we've incorporated the Cpax assessment into the overall mobility program.
Sure, thanks, Sarah and Deb. So I guess, yes, there was definitely some anxiety before we launched the program, and we actually did a survey of perceptions and knowledge regarding early mobilisation, as well as other aspects of PICU liberation before we launched the program, to see where people's concerns were mostly. And they were mostly related to extubations and attachments, drains and lines. And worrying that perhaps we were going to be getting all the ECMO patients up and walking. And once I had reassured them that at this point in time, we will be starting slowly, and that our program is very much evidence-based and based on very sound precautions and contraindications that need to be worked through before we mobilise the patient. I think that has really built a lot of confidence, and the fact that the medical staff are very involved in establishing the goals, so people feel like they are backed by the medical staff, the nursing staff and the allied health staff before they actually do the mobility activities in these critically ill patients. The second part of the question, how do we incorporate the Cpax, the Children's Chelsea Physical Assessment Score? So that is really used as a bedside tool to monitor the child's level of physical function and over their PICU stay, as well as using it to help build really targets for targeting their physical rehabilitation and their physiotherapy, their occupational therapy, and the areas that really needs to focus on. And it is put up at the bedside, the score on a radar chart, so it's visible for staff and patients and parents to see, and that really helps with giving a visual cue to work towards our goals. So yeah, it's working well like that.
Thanks, Ali. I think we have run out of time, and I'd like to thank everyone for joining us. I think there at one point we had close to 50 participants, so thank you everyone for listening. It's nighttime here now in Australia and Oceania, so it's time for us to go to bed. I know for a lot of you, your day's starting or it's halfway through. So we wish you a very nice day. And for those of us in Australia, good night to everyone. And thank you to WIFPIX, and we look forward to seeing you at the next webinar.
Thank you so much for the opportunity of presenting on behalf of Oceania. I think it's been a really, I hope you've enjoyed watching our webinar, and thank you so much for the questions.
Thank you. See ya.